Okay, well, I'm back. This is part two of the cardiac dysrhythmias. If you're looking for part one, it's in another video. So I finished talking about the atrial dysrhythmias, atrial um, flutter, and atrial fibrillation. So let's talk about premature atrial contractions, or we call them PACs. PACs basically is when an irritable site at the atria fires before the next SA node impulse. And so they don't look all beautiful rounded P waves. They almost look like a spike and with a little dip to them. As I circle them here, just for you to view, look at the difference between those that I circle and the other ones that don't necessarily are circle. So you can see that there's a difference. Pretty much this is caused by stress or fatigue, caffeine, tobacco, COPD or lack of oxygen, and as well as the electrolyte imbalance. The signs and symptoms is like the individual, the client feels like skip a beat, and also palpitation. Sometimes there's not even signs or symptoms. We basically treat it by identifying the cause, avoiding any triggers, and then treat it if applicable. Sometimes we can give them beta blockers to decrease those PACs. They're pretty simple. Now, premature ventricular contractions, PVC, it's not really a rhythm, but it's basically when an ectopic beat that comes from an irritable side at the ventricles. And, they look very bizarre within the beats or within the QRSs. If you look at the circle one that I have here, if you notice they're wide and it kind of has that drop on them. So they're very recognizable. You can see them in an EKG very well. And the problem with these is that we got to be careful because many of these PVCs can lead to a more deadly dysrhythmia. So, anyways, we care about them, and even though they're not a rhythm, it's more of a beat. We do pay attention. So again, it has to do with stress, caffeine, nicotine, or exercise. Some heart diseases like heart failure, electrolytes, and fever. I see them a lot with stress personally, as well as lack of oxygen. Some of the signs and symptoms could be dizziness, hypertension, and palpitations, and we can treat them with oxygen. You treat the cause. So, for example, electrolyte, get an electrolyte order to fix the imbalance, and sometimes beta blockers or amiodarone. All right, the next are our deadly rhythms, and these are the ones that we really pay close attention because they'll deteriorate very quickly, and your individual client can die very quickly. So they're called the ventricular rhythms. The first one is ventricular tachycardia. Again, that is why we care about PVCs, because PVCs can lead to ventricular tachycardia, 3 or more. I recognize them in a strip because I call them the big mountains. So they are big mountains. Think about big Colorado mountains here. And so, what can be the causes for these? Well, usually a very sick heart, ischemia, or heart attack, certain medications, big time electrical imbalances, not electrical imbalances, electrolyte imbalances, excuse me, or congestive heart failure. The signs and symptoms, well, they could, initially have some chest discomfort. They'll be alert sometimes initially, very quickly, but However, it can deteriorate very fast, and you might lose them where you can just they could stop breathing, they could stop having a pulse. So here you have to implement your ACLS protocol. No pulse. You start chest compressions, and then you give different drugs to basically bring that rhythm back. Um, if you have a pulse, you want to give oxygen, get an IV immediately, and monitor the client, and then reverse whatever needs to be reversed as soon as possible with medications like amiodarone and some beta blockers as well. Um, for chronic or recurrent VTs, what we do is antiarrhythmic medications, and most of the times they have to have an implantable cardio defibrillator. So in case that the heart goes into a ventricular tachycardia rhythm, basically the heart or this defibrillator implanted in their chest just defibrillates the heart. But pretty much you do over here like CPR if they don't have a pulse. Then for ventricular fibrillation, these are like most of the times the patient is completely out of it. They're not breathing. They don't have a pulse. They're not responding to you. And if you notice, the mountains are smaller. So they're not the big mountains anymore. I call them the small mountains. So you don't have any ventricular contractions here, barely anything. And so that's why the mountains are smaller. Um, Again, untreated VT can lead to this, electrolyte imbalance, MIs, trauma, some of the, some of the causes, signs and symptoms. Pulse is absent, client is out of consciousness, you initiate CPR, and you start your ACLS algorithm, and you defibrillate whenever there's a shockable rhythm. Um, then the other ones are asystole versus pulseless electrical activity, or PEA. Asystole is when there's basically no activity, no ventricular contraction. They are flatline, what you see in most movies and shows. There's nothing. However, when we have pulseless electrical activity, we see a little bit of something, a little bit of a rhythm, so to speak, or activity in the EKG, but the client does not have a pulse. So that's why we call it pulseless electrical activity. So we treat it the same way as if there would be no pulse, or just a flat line. We do CPR. Okay. So let's look at the signs and symptoms: loss of consciousness, pulse absence, a treatment, CPR with ACLS measures. Now let's talk about the difference between defibrillation versus cardioversion. So when we defibrillate, is that we're sending an electrical discharge through the heart to basically depolarize those cells of the heart, and get that electricity back on so the heart starts pumping again. Cardioversion, you are sending electricity, but it's at a lower energy joules. And it also has to do, it is kind of like time with just the contraction of the ventricle. So at the R, at the QRS. So that is why we don't cardiovert someone that is on ventricular fibrillation, or just asystole, because they don't have a QRS, they don't have anything, any contraction. It's synchronized, so you have to make sure that you turn on the synchronizer. versus the defibrillation is there has to be a shockable rhythm. Um, and the machine is like automatically analyzes the rhythm and tells you, okay, shockable rhythm, defibrillate basically. Um, so that those are the main difference. Here's a chart kind of like separating, so not synchronized, synchronized on the R. For cardiac arrest, defibrillation for patients with arrhythmias that are unstable. Defibrillation is higher joules, cardioversion is not that high, and so on. Here's another one. Also for cardioversion, sometimes we can give them a little bit of sedative because they're awake, and so that way it doesn't hurt them that much. And then let's talk about pacemakers. So pacemaker, I mentioned on my first video that sometimes we have to implant them on people where they have um, conditions such as sinus bradycardia to basically tap the heart a little bit and say, hey, wake up, and you got to beat faster. And so they are inserted. Here's a better picture of it. They are implanted in your chest, and electrodes, the electro leads go up to your atrium and your ventricle, right atrium and right ventricle. And basically, when they recognize that the heart goes below the set limits of the pacemaker, sometimes it's below 40, etc., then it kind of sends that electricity. Um, but really here is understanding what it does, but also the teaching that goes behind it when you are caring with for someone that has a pacemaker. So first of all, they have to follow up regularly with the physician to make sure that the function of the pacemaker is working and that it doesn't require batteries. Some of them need to be their battery needs to be changed every so often years. So that's something that we educate the client. Also, is implanted in you, so they have to carry uh, like a card that anything that is implanted in the body, the manufacturers give. That it tells anyone if it's MRI safe and whatnot, whatnot. The incision needs to be monitored for infection. It also needs to be kept dry for 4 days after the implantation. You have to report any signs of discharge, fever from the incision site, swelling, etc. You don't want to lift that side of the arm higher than your shoulder until cleared by your doctor, and usually is several days, a week or two. You want to avoid any direct impact or blows to that area or the pacemaker. For example, falling on that side or playing sports like football or soccer that is going to hit you directly on the pacemaker. Avoid any proximity to high performance electrical generators. You have to know if it's MRI approved, and if you are not sure, then they don't go to MRI unless you have that little card that I was talking earlier that says the pacemaker is MRI safe. It's better to, I guess, pretend that it's not and save the client that assume that it is, and then it's not, and then the MRI just pulls it out of the chest. Same thing with the use of microwave is safe for the clients, and also traveling through the airport through TSA is not restricted. So you want to make sure that the clients also know that. So in your book, there's some education or teaching material that we need to do for pacemaker. I kind of gave you an overview, but you really need to look into that. Okay, I show you this picture, and again, my references are from the book and all my images are from Google. I hope this was helpful, and I will see you in the next video. Bye-bye.